Perfect. Thank you so much, sir. So again, my name is Judd Mal. I'm a urologist at Duke University. Dr. Larry Karsh is a urologist in Colorado, Denver, Colorado, Urology Center of Colorado, and Dr. Alicia Morgans is at Harvard. She's a medical oncologist. This is our multidisciplinary program on advanced prostate cancer. I think Dr. Karsh and I were discussing it. This must be, I think, the 10th year. So, I hope the AUA does, maybe they'll boot us out, but we've had a 10-year run on this since Provenge, I think, and things have changed a lot. I want to read some statements that we're supposed to do at the beginning of the course. AUA policy states that all planners, authors, and presenters must disclose prior to their presentation all financial relationships with any commercial interests. These disclosures are also posted on the AUA annual meeting website. No photos, video, or audio recordings are permitted. I know that's a bummer. I'm on Twitter, but I guess I'm not allowed to send any tweets. Courses are selected based on evaluation results. For every course evaluation that you complete, your name will be entered into a drawing for a complimentary Porsche 911. Oh no, it's a registration for AUA 2023 in Chicago. Winners will be announced in June, and you can evaluate the session for every course. You can evaluate the session on your AUA registration, select evaluate through the credit claim process, or you can go to the AUA 2022 mobile app. The other thing, we're delighted to say that this course has been selected for live stream, so I want to welcome everyone who is joining us virtually online. And so without further ado, I'm going to turn the podium over to Dr. Karsh, who's going to give the first presentation.
Thank you, Judd. It's an honor to be here again with you for I don't know how many years we've been doing this together, and as well as Dr. Morgans, who joined us for the first time this year. So I'm going to be talking about metastatic hormone-sensitive prostate cancer. Let's see. You have to navigate these slides. Is the control? That's it.
What about on the laptop? Is it not showing?
It's not on the laptop. Okay. Got it. Okay. So these are my disclosures. And I'm going to start with a tale of two prostate cancer patients with metastatic hormone-sensitive prostate cancer. So the first one, a 65-year-old male who was diagnosed with Gleason 6, 7, and 9 prostate cancer and had a PSA of 6.3. He underwent a radical prostatectomy. His bone scan and CT scans were negative. His post-op PSA was 0.13. He had ADT for 6 months along with external beam radiation. PSA became non-detectable. And that was in 2016. 2020, he comes back with a rising PSA, 0.9, and it went up to 4.94. We did a CT and bone scan, which was negative. He had a flucyclovine PET CT, which demonstrated some periaortal and aortal caval lymph node enlargement. He underwent SBRT to those nodes. We tried to see if we could make him ADT free. PSA nadir'd at 2.88. And then at the end of 2021, his PSA went up to 8. We did not have any kind of PSMA imaging at that point available, but we did a CT scan, and a bone scan was negative. His CT scan showed that those nodes actually got a little smaller, but his PSA was up, and in early 2022, it was up to 13.8. We still could not get a PSMA CT because it hadn't been operationalized yet in our neighborhood. His CT nodes were increased, and he had 3 bone lesions in the pelvis and 1 in the rib, so he had 4 bone lesions. We did germline testing. It was negative. We didn't have tissue available to check for P10 loss. That's one of the studies that we look at. And he did not want to undergo bone biopsy, and it was very difficult to try to get those nodes that were in his retroperitoneum. So we did not have any tissue testing. So You diagnose high volume metachronous. Now, metachronous is a new term that we're using for recurrent cancer after primary treatment with radiation or surgery. But you're going to see that terminology floating around now. But how would you treat this patient? So this is not, we don't have ARS for this, but I'm going to kind of get a show of hands. How many would treat this patient with ADT? ADT only. How many would do ADT plus a novel hormone like ABI or ENZA or APA? Okay, good number. How about ADT plus 6 cycles of chemotherapy? We have an oncologist in the group back there. Okay, and how about D, ADT plus NHT and 6 cycles of docetaxel? Who would do that?
Yeah.
That's what I meant.
Okay, all right. And then a clinical trial. We always offer clinical trials, but we're going to come back and discuss these questions a little bit more. Case 2, we have a 55-year-old male who was diagnosed with Gleason 9 in 2022, earlier this year. He had a PSA of 55. He had CT and bone scans were negative. And he was scheduled for a radical prostatectomy. He came to see me for a second opinion. We managed to get a PSMA PET CT, and he had to go to San Diego from Colorado to get it because we didn't, again, have it operationalized. We do now. We have more and more that we're doing. But he had diffuse pelvis, retroperitoneal, and mediastinal nodes that were positive, as well as a bone met in his pelvis. He underwent germline and somatic testing. We had fresh tissue from his biopsies for the testing, and he was BRCA2 positive. He was P10 proficient, so we did not have P10 loss. Now, when you do somatic testing, you might see some of these HRR mutations, but unless you do germline testing as well, you don't know if it's germline, because sometimes you can have it in the tissue and it's not germline, but he had germline, and it will show up in the tissue as well. So you diagnose low. Now I have a question mark here, and this is for our panel. Later we'll have a little discussion. Is this really low, or is this high volume de novo metastatic hormone-sensitive prostate cancer? And he was BRCA2 positive. So how would you treat this patient? ADT, anybody? Okay, ADT plus NHT or 6 cycles of docetaxel. Okay, how about ADT, NHT, and 6 cycles of docetaxel? Not too many, okay. How about ADT and a PARP? Okay, we'll talk about all these answers, and then we also have a clinical trial. So, go ahead.
I was just going to, so do you think that, I mean, I agree with your management, although some people may argue that because he was young and healthy, he might have should have had the radical prostatectomy, even though you would diagnose the metastatic disease later. And I know there's no level 1 evidence, but gosh, with that prostate, just playing devil's advocate as a surgeon.
You are exactly right, and we are going to consolidate his treatment, but we felt it is important to treat him systemically now, because he, even though he's got diffuse node disease and a 1 bone lesion, he could, and we can have this discussion a little later, but PSA 55, we'll talk about some of these characteristics of some of the patients in the charted in Latitude trial. But this is, there aren't too many papers that are still quoted, like this seminal paper from Huggins in 1941, where he described treating patients, metastatic patients with ADT. And really 80 years later, ADT is still the foundation treatment for metastatic, whether it's metastatic hormone-sensitive prostate cancer. It's still the foundation treatment. And that was really until 2015. Now that we have the intensification era, so now that really seems to be the standard of care. But we have intensification with docetaxel, then abiraterone, then apalutamide, enzalutamide, and now darolutamide is getting into the mix. So there were 2 Nobel Prize laureates in prostate cancer and in ADT. Charles Huggins, he didn't get that Nobel Prize until 1966. And then Andrew Schally in 1977 for his discoveries that led to leuprolide development. So what's new in ADT? We have an oral antagonist now. It's relugolix, and it met its primary and secondary endpoints of sustained castration and non-inferiority to leuprolide. You know, from 1940 until 1985, the mainstay treatment was surgical castration. Then we get the analogs that were developed in 1985. So we had injectable leuprolide in 1985. And then we had an injectable antagonist in 2008. And now we have an oral antagonist. Now, there was a 54% reduction in the risk of major cardiovascular events in this HERO trial. But there's a caveat here. This was not a pre-specified endpoint in the study. It was a pre-specified safety analysis that the FDA wanted to determine whether or not there were more or less MACE events. Now, there's been a number of studies that have been done and a lot of pooled analyses. They were non-propensity matched, and they suggested that there were less cardiovascular events with the antagonist. There was really only one study that was set out and designed to compare the antagonist to the agonist and determine whether or not there were increased cardiovascular events. And it was the PRONOUNCE trial, and it did not show a difference. Now, the caveat is that they planned to put 900 patients in the trial. It was very difficult to accrue. They had some very strict requirements for cardiovascular events. It was an adjudicated study, whereas in the HERO, that was not adjudicated. But it was an adjudicated study. And although they didn't get the number of patients that they wanted, they did look at the results earlier after about 500 patients and did not find a difference. So this is the clinical states model. We're focused on Hspc, newly diagnosed or de novo, or primary progressive who have occurred after primary treatment like radiation or surgery. And again, there's a new term we're floating around called metachronous for that. But regardless, when these patients progress on ADT, they then are now they're metastatic CRPC, which is the lethal stage of this disease. So we define metastatic CSPC as metastatic disease, and patients have not progressed on ADT or have not started ADT. But you're going to see a lot of different terms in the literature that mean the same thing. Metastatic hormone-sensitive, metastatic hormone-naive, metastatic castration-naive, metastatic non-castrate prostate cancer. But regardless, these are all patients who have metastatic prostate cancer have not yet developed castration resistance. So are there differences between de novo versus progressive disease or patients who have progressed after local therapy? Well, there's not a lot of high science and data out there. And there's an intrinsic belief that de novo disease has a more aggressive biology. So this was a small study, it's retrospective, but it would at least suggest that, in fact, patients with de novo disease do worse. So these are all the approved agents for metastatic CSPC based on these studies. We have docetaxel, Abi, enzalutamide, apalutamide, and soon we'll probably see darolutamide on that list. But one thing that I want to say is that all of the studies that we have done and we continue to do are based on conventional imaging. So I know there's a working group that is trying to figure out how to integrate the advanced imaging into these clinical trials, and maybe I can ask Dr. Morgans here at the end here what she thinks and if we're going to start seeing more trials with advanced imaging in those trials. But let's look at the characteristics of the enrolled patients in the Charted, Latitude, and Stampede. Charted was a volume definition. High volume was presence of visceral mets and 4 or more bone lesions with one outside the axial skeleton or the vertebral bodies and pelvis, and the alternative was low volume. Latitude was a little different. It looked at a pathologic and volume definition. So you were required to have at least 2 of these 3 prognostic features: a Gleason score of 8 or greater than or 3 or more bone lesions, and measurable visceral mets. And this is not terribly inconsistent with a high volume group in Charted. Stampede, different. It included M0 patients, so that they were newly diagnosed metastatic, node positive, or high risk locally advanced with at least 2 of these 3 features: T3-4, Gleason 8 to 10, and or PSA of 40 or greater. So the question now is intensified treatment up front better? Is earlier treatment better? And this is what we're going to try to answer in showing you these studies. But the revolution really began in 2015, and it started with Charted. And docetaxel was approved previously based on the SWOG 9916 and TAX 327 in metastatic CRPC. There was a 2-month survival advantage. We didn't get real excited about it at the time, but between 2004 and 2010, there were really no other therapies approved with an overall survival. Until we got to the Renaissance era, and then we have all of these other therapies, immunotherapies, the ABI, ENZA, radium, another chemotherapy, cabazitaxel. Those have all been approved since 2010 for metastatic CRPC based on overall survival. In Charted, upfront docetaxel increased median survival by 13.6 months in the overall study, and this was confirmed simultaneously with Stampede. So this intensification really began in 2015, and this really led to us thinking that hitting the prostate cancer hard and early is critical to long-term control. Now, when we broke down the Charted study, we found that really only the high-volume patients were the ones that benefited. Even though in the overall study, you can see an HR of 0.73, the low-volume patients really didn't show a benefit, and you had a hazard ratio of 1. And so when you looked at the high volume, that was about 17 months difference between using docetaxel and ADT versus ADT alone. And this revolution continues with abiraterone. Abiraterone was first approved in metastatic CRPC based on the Cougar 301 and 302 trials in the post-chemotherapy and then pre-chemotherapy, and overall survival was demonstrated. And as far as upfront abiraterone, it was shown to show a survival advantage in the Latitude study as well as the Stampede trial. And it's not surprising that in the final analysis, it held up and it remained important and compelling, and patients had about a 16.8 month survival advantage. Now, in Latitude and Stampede in these trials, they did not allow docetaxel. Again, it had not been approved, or we didn't see the data from Charted when these trials were being developed. And Stampede, a little different trial design, but it's almost a mirror image of the results. The overall survival was almost exactly the same in the Stampede trial, looking at ABI and ADT. So this revolution is validated by ARCHES. ARCHES looked at using enzalutamide and ADT. And enzalutamide was first approved in the AFFIRM trial and in the PREVAIL trial, so it was post-docetaxel, then pre-docetaxel, and there was survival advantage in both. And enzalutamide also delayed metastases in the PROSPER study in non-metastatic CRPC by 22 months, and later we saw a survival advantage that was linked to that. So upfront ENZA and ADT improved overall survival by 34% in the ARCHES. Now there's one thing that was different about the ARCHES trial. The primary endpoint was RPFS. OS was a secondary endpoint. It was approved based on the RPFS. Now they did not have mature survival data at the time, and that's why I'm mentioning ENZAMET. ENZAMET read out at around the same time as ARCHES, but their primary endpoint was overall survival, and it was demonstrated in that trial. Now, again, the ARCHES and in some met trials, they allowed docetaxel, but they didn't have enough patients to really power that to tell a difference between whether or not triplet therapy was better than doublet therapy. But enzalutamide, again, it was approved in MCRPC, and then later in the PROSPER trial, showing, again, we talked about the extension of the metastasis-free survival. And upfront, enzalutamide improved overall survival in that ENZAMET trial. Now, the ENZAMET trial was done in Australia and New Zealand, so it wasn't used for approval here. But there was only one site in the United States that had the ENZAMET trial, and that was Dr. Morgan's site at the Dana-Farber. And it's no coincidence that Chris Sweeney, who was the principal investigator, enrolled patients on that study. And this revolution is further validated with Titan, and apalutamide was first approved in non-metastatic CRPC in the Spartan trial, and there was a delay in metastasis by 2 years, and later we saw overall survival advantage with apalutamide. Now, looking at it in the Titan trial, the final analysis, overall survival, they had co-primary endpoints of rPFS and overall survival, and it met both those endpoints. So, based on all of this level 1 evidence, the AUA, ASTRO, SUO guidelines give offering apalutamide, enzalutamide, or docetaxel a grade A or highest level category for recommendation. Now, the nice thing about the AUA guidelines are you see these little brief guideline statements, and then you can read more about where they got there as far as the evidence. But it's easy to navigate, but they gave it their highest level evidence. And you can see the same thing in the NCCN guidelines. Now, notice here that they use castration naive. So we're seeing these terms for the same disease state being used differently. But they also give it category 1, which is their highest recommendation of using ADT plus ABI, APA, docetaxel, or enzalutamide. And I think soon we're going to see darolutamide involved in that mix. So in selected patients with Hspc with low volume disease, clinicians may offer primary radiotherapy to the prostate in combination with ADT. Low-level evidence, it was based on a study in Stampede, where you can see when we look at the high and low burden that really it was the low burden patients that benefited from adding radiotherapy. So, you know, with all this evidence out there, why are we not intensifying ADT per the guidelines? We don't have an answer to that. In fact, there's a lot of smart people that have been trying to figure this out, and we put on programs like this to educate everybody. But you can see from the VA that 77% of patients up in 2018 got ADT only or a first generation, ADT plus a first generation anti-androgen, so that only 24% of patients received guideline-recommended intensification. And we see that in Optum Health Insurance, and this was a study that Scott Tagawa put together, but you can see that only 29% of patients received intensifying therapy recommended, and the rest of these patients received ADT only or ADT and an anti-androgen.
I was just going to make a comment that, and I wish I was trying to get the data to show at this meeting. We're working on a similar follow-up study on a different administrative data set, and even as late as 2021, it's just as bad. I mean, it's embarrassing how bad it is in the United, and I, as a urologist, it's worse among urologists than it is among medical oncologists.
I think it's amazing, and we're all scratching our heads about this. And this is Dan George at your institution who looked at this community oncology groups. And again, 44% of patients are being treated with adequate intensification, and the rest are not. Now, you're seeing a trend here where we're starting to see patients getting ADT plus novel hormone therapy, Docetaxel has gone down, but if you look at that green line, ADT is going up. So, and I think, Judd, that's your point. I think if we get that data out now, we're probably going to see that we're in the wrong direction still. And then when we looked at SEER data, Medicare patients, 83.5% are not being intensified according to guidelines. And then off to the right there are the guidelines I showed you from the NCCN. So can triplet therapy further improve outcomes in metastatic hormone-sensitive prostate cancer? Well, there are a couple of studies out there. Piece 1, this is the Prostate Consortium of Europe. It's a complex study. It's a little hard to follow, and they have this 2x2 factorial design. But what they're looking at is de novo metastatic castration-sensitive prostate cancer patients in their 4 arms. So you have ADT with or without docetaxel, ADT with or without ABI, ADT with or without radiotherapy. But they originally started, they wanted to enroll, they got 1,173 patients in. But the standard of care up until 2015 was just ADT alone. Then after 2015, they made the standard of care ADT plus docetaxel. So, and their primary endpoint was RPFS. But if you see the results here, and this was presented by Karim Fizazi at ESMO in 2021, you see that there is an improvement with triplet therapy in overall survival. And if you kind of try to put this all into the context of recent data, adding abiraterone to ADT plus docetaxel improves RPFS and OS. Even when 84% of men that develop metastatic CRPC from the control arm received androgen signaling therapy. So toxicity was as expected for each, the abiraterone as well as the docetaxel, and there were no new safety concerns. But if you put this all into context, and if you look at, this is what Dr. Fizazi presented, ADT alone about 3 years. You do ADT plus docetaxel, you're getting close to 4 years. ADT plus abiraterone about a little over 4 years. And then adding ADT, docetaxel, and abiraterone, we get out to about 61 months, so it's 5 years. So this is what they were able to show in their study, and it added a year and a half after adding other intensification with doublets. Now, Arisens, this is not an ongoing trial anymore. It's already completed, and the results were read out by Matt Smith at the ASCO GU, and it was looking at ADT plus docetaxel plus or minus darolutamide. 1,300 patients were enrolled. The primary cutoff date was in October 2021, and it was a positive study. The primary endpoint was met, as well as all these other secondary endpoints. And it was in de novo and as far as recurrent disease. But they do know high and low. They haven't shared that with us yet. The difference between whether the high volume group or the low volume group benefited more or both. But they tell us that they're going to be reporting that at some point. But the results were that they had an improvement in overall survival by using the triplet therapy. And it's kind of what they showed in the Piece 1 trial too. Triplet therapy was better than doublet therapy. But I think we need to define which patients are going to respond the best. And when they looked at the combination in the de novo and recurrent groups, they still had overall survival advantage. It's kind of interesting that de novo didn't have as well of an advantage as the recurrent group. And I showed you that first slide that showed that de novo was probably a more aggressive biology. So now we're going to shift gears. We're going to talk a little bit about genetic counseling. Now, I'm not a genetic counselor, but I did stay at the Holiday Inn. So, no, I actually, I finished the course, City of Hope, Cancer Genetics. I just completed that. So I know a little bit, enough to be dangerous, but we do offer genetic counseling. We have a clinic now that we've set up. so that we will take our high-risk localized disease and all metastatic patients and offer them germline testing. And so I do a little bit of counseling to these patients just to talk about the benefits and risk of doing the testing. We send it off to these companies, and if the insurance doesn't cover it, it's a pretty low cost. But I think germline testing is important because it informs not only the patient of some future treatment options and whether or not they're going to have a more aggressive disease, but it informs the family. I recently had a patient who was BRCA2 positive. We went through the cascade testing, and it was done, online through one of these companies. I can't mention names, I guess. But it ended up that he's had 3 other people in his family that were BRCA2. A niece, she was 34 years old. She just underwent a salpingophorectomy and thinking about bilateral mastectomy, and her 2 daughters who are young. And so it's interesting to see what you can unravel. We think that probably about 10-12% of patients with metastatic CRPC have germline mutations in the HRR mutations.
I just wanted to make a comment. I don't know if anyone was in the session this afternoon. A group from Italy gave a very interesting presentation this afternoon looking at how a high percentage of patients actually refuse this testing, and that comparing northern Italy to central Italy to southern Italy, they found a big difference in uptake, that patients were not willing to actually undergo this testing. So I think that we may face this problem, and I don't know if there's any similar data in the United States, but I would bet you in my practice, quite a few patients, lower socioeconomic patients, would probably refuse.
There are a number of patients that refuse, and I had one where this guy was in the upper socioeconomic. He was BRCA positive. We put him in a trial, but I talked to him about having his family tested. He says, "No, I don't want them to know." Now, that was kind of unusual. But he says, "I've got a granddaughter who, if she has it, she's not going to be able to get married." So, you have all these different fears. We're involved with Dr. Guri. She has a study called Progress at the Kimmel Cancer Center, and it's a registry. And so we hand that out to all our patients, but they do that online, and it talks to them about why or why not they decided to have testing done. So we're going to try to find some of these answers out. But I think it's an important thing to offer patients, especially germline first. That's how we do it. But these are the NCCN guidelines. You have AUA guidelines. But generally, this is just kind of an encapsulation of, patients who have high risk, very high risk, regional or metastatic prostate cancer, Ashkenazi Jewish ancestry, family history of male or female breast cancer, ovarian cancer, pancreatic cancer. That's a signal. And you also can pick up other mutations when you do germline, like Lynch syndrome genes. So I think it's important. As far as somatic tumor testing, we're kind of holding off on that until, some patients, I offer it to them. Some of them want to have it done right up front. But we really want to wait till we get something actionable. Once we get to that point, then we definitely get somatic testing. And not only do we look for HRR mutations with somatic testing, you also look for other things like microsatellite instability, DNA mismatch repair, as well as tumor mutational burden. Because those patients, there's an agnostic indication for pembrolizumab in those patients in any solid tumor. So don't forget about bone health. Every time we start somebody on ADT, we talk to them about vitamin D and calcium, exercise, smoke cessation if they're smoking. We get a baseline DEXA and FRAX. And if they need anti-resorptives, we'll start them on low-dose denosumab or low-dose zoledronic acid. Usually it takes a little time, but I have some older patients who walk in the door with osteoporosis. Now, we don't have too much data on whether or not to use the high-dose denosumab or zoledronic acid in patients with metastatic hormone-sensitive prostate cancer. But this was by Matt Smith from the CALGB group, and this was published in 2014. And they looked at whether or not patients would benefit that had metastatic hormone-sensitive disease as far as skeletal-related events, overall survival, and so they looked at these parameters, and there was no difference. So there really is no benefit that we can tell so far to starting patients on that have metastatic CSPC, starting them on high-dose anti-resorbers up front like we do with metastatic CRPC. So what's on the horizon for metastatic HSPC? These are some studies that we're doing in our clinic, and I'm sure there are others. And maybe a lot of you are doing these studies, but this is Capitello, and it's looking at de novo metastatic HSPC with P10 loss. And it's looking at capivasertib plus ADT and ABI versus placebo plus ADT and ABI. RPFS is the primary endpoint, overall survival is the secondary endpoint, but they think that they're going to have to screen 5,500 men in order to get 1,000 that have P10 deficiency. And this is capivasertib's an AKT inhibitor. Another study, TALAPRO-3, kind of a similar design, and these are patients that have CSPC, and they have to be positive with bone scan and CT scan, conventional imaging. That's the other studies as well. They can have had docetaxel, the Capitello study, they couldn't. And what it's broken down to is ADT plus enzalutamide plus or minus talazoparib, a PARP inhibitor. And you can see the primary endpoints are kind of similar to what they use in Capitello. And there's another study, Amplitude. And in the TALAPRO, they have to be HRR positive to get into the study. We did a study in TALAPRO-2 where they looked at all comers and they decided that they had to be HRR positive to get a benefit. And they've just had an amendment on TALAPRO-3 saying that patients with ATM are not going to be included. So they're breaking it down to different HRR mutations. But Amplitude looks at similar patient population, and they have to be HRR positive, and you can see all the genes that they're looking at down there on that lower line. But it's 1-to-1, niraparib plus ABI and ADT, or placebo plus abiraterone and ADT. And again, you see similar kinds of endpoints and some stratification factors. So there are ongoing clinical trials. The ARANOTE is going on outside of the U.S., and that may answer the question of, does docetaxel really give you much more benefit over ADT plus terralutamide? So we're going to see those results probably in a few years. There's Keynote 991, which is ADT plus enzalutamide and plus or minus pembrolizumab. So these are the future directions. I just showed you all the studies that have pretty much been completed in an MHSPC. These are the ones that are in progress. We've had a couple of studies in active surveillance, which we're waiting for some readouts, as well as high-risk localized advanced disease, ENZARADs using enzalutamide plus with radiation. Stampede's looking at an ABI. Atlas is looking at apalutamide, and with a radiation. Proteus is a surgical study where they get 6 months of ADT plus or minus apalutamide for high-risk patients, and then the same regimen 6 months after their prostatectomy, and that's in progress. And then EMBARK, which is still in progress, is a biochemical recurrence study looking at enzalutamide monotherapy versus ADT or ADT plus enzalutamide. So this is what we're going to conclude with. ADT monotherapy is no longer the standard of care. Treatment intensification strategies are stratified by high or low volume. Docetaxel is really high volume. You can see ABI, APA, and ENZA, high or low volume. And pretty soon you're going to see darolutamide added. They've gone through an expedited approval. So they're not approved yet, but on May 3rd, the FDA announced that they're going to put them on the fast track to try to determine whether they get approval. Triplet therapy, which includes ADT, docetaxel, plus or minus DARA or ABI, demonstrated overall survival advantage and should be considered. And we can talk about that, which patients should we consider that in. And triplet therapy with ADT and ABA or ENZA, ABI or ENZA with PARP inhibitors, AKT inhibitors, checkpoint inhibitors, they may be beneficial, but further efficacy and safety trials are needed and are underway. Consider radiation therapy to prostate to the prostate in low volume disease, and germline genetic testing is recommended for all patients with metastatic and high-risk localized prostate cancer. So we can go back to our cases. Do we have time to go through these now, Judd? Okay. So this was case number 1. Just to review, this is a 65-year-old male with a history of Gleason 6, 7, and 9. PSA was 6.3 when he presented. CT and bone scan negative. He goes through a radical prostatectomy. His post-op PSA was not non-detectable, and he gets 6 months of ADT and external beam radiation. PSA becomes non-detectable. 4 years later, PSA is going up. CT and bone scan were negative. A flucyclovine PET CT demonstrated lymph nodes that were treated with SBRT. He had continuing rise in his PSA. His CT and PET scan and bone scan at the end of 2021 just demonstrated some improvement of those retroperitoneal nodes, and his bone scan was negative. PSA goes up to 13.8 in early 2022. We got we did CT and PET scan conventional again, and we did see 4 bone lesions, and the retroperitoneal nodes had been increasing in size. Germline testing was negative. Patient did not want to undergo any somatic testing, so we didn't check him for the Capitello study. Now, we can also do liquid testing if patients don't want to have tissue testing. There is a high concordance rate. It's not quite like tissue, but I think it's about an 85% concordance rate using liquid or blood-based somatic testing. So we're going to see what people would do at this point. He's got high volume disease, and would you do, and based on what I just showed you, would you do ADT alone? Anybody? I don't think there was anybody that would do that. ADT plus NHT. Okay, we moved the needle a little bit. ADT plus 6 cycles of docetaxel. Okay, we have somebody out there. How about ADT plus NHT and 6 cycles of docetaxel? All right, so looks like we moved the needle a little bit.
The only thing that some people might say, and even though you didn't present that, I don't think, is that when you made the comment that de novo metastatic disease is worse than the term
Metacrinus.
Metacrinus. So this guy had metacrinus, so his prognosis should be a little bit better. Mm-hmm. So therefore, some might make an argument for ADT plus NHT.
Or 6 cycles of docetaxel.
Yeah, I don't know.
Yeah.
I'm just...
No, and I think what we need to do is try to define who are the high-risk patients that need triplet therapy. Alicia, I know you're trying to say something.
Yeah, thank you. My microphone doesn't work, but maybe somebody could help us with that over the course of the next little bit. Anyway, just to comment on, thanks so much. So just to comment on that exact point, I really appreciate you raising that. So the PEACE 1 trial and the majority of the patients in ARASENS had de novo metastatic and high volume disease. So it's really an interesting question. I think that it's a bit of more of a slam dunk to say de novo metastatic, high volume disease, the triplet in chemo-fit patients is absolutely what I would say I would offer a patient as a medical oncologist. Again, chemo-fit patient is really important to start off with because there will be patients, of course, who are not going to be chemo-fit. But that triplet combination seems to be such a, if they're chemo-fit again, not a substantial increase in morbidity in terms of adding that AR targeted agent onto the docetaxel if that is something that you're planning to do anyway. But in the recurrent setting and in the low volume setting, there's more of a question of whether the triplet is really necessary and whether it's actually going to be beneficial. In low volume metastatic hormone-sensitive disease, based on the charted trial, we don't necessarily always offer chemotherapy, or at least I don't, unless the patient is young and really pushing that that's of interest to that individual. So this metacrinus setting is still being worked out, and I think the data is to come, but that's a great point, and this is where shared decision-making and a multidisciplinary clinic conversation, I think, can be really, really useful.
Right, and the patient has to be involved in that decision-making too. Some of them don't want chemotherapy.
I got to ask you one other question. For the urologist in the audience and for Larry and I, is there an easy way for a urologist to determine chemo fit? Because, I don't know when, I don't want to burden all my medical oncology colleagues. I can treat some of these patients myself, but I don't want to miss the opportunity for docetaxel and have them get,
Sure. So, good. Thank you. So I judge chemo fit, which can be a gestalt, like you said. Medical oncologists we just kind of have it when we know when we walk in the room for the most part. But what I do talk to patients about is whether they are up and moving around at least 50% of their day. That I think is a pretty easy nugget to kind of tuck away and think about. And I'll talk about chemo when people will say, yeah, that's okay. So I'm over exaggerating that just a little bit. But there are patients who need to have chemo and they say, yeah, I can do it. But then I ask that follow-up question, are you really up and moving around half of your day? Are you really pretty independent in most of your activities of daily living, taking care of yourself, dressing yourself, bathing yourself, feeding yourself, some of the instrumental ADLs like feeding yourself, checkbook and stuff? Maybe we don't necessarily need to use those to judge, but certainly the very basics and moving around 50% of your day, which is the ECOG performance status of 2, basically. So if they are not, it is very possible that chemotherapy will cause more harm than good and may shorten their life expectancy. So that 50% up and moving about during the day, I think, is really helpful.
Those are some good points.
Excellent.
And, I might also say ADT monotherapy is not totally out the door. There are some patients who are not fit. Not only are they not chemo fit, but they're not fit to add on other therapies. I think it's a minority of patients that I've seen that wouldn't tolerate an NHT, but you have to keep that in mind. But those are some great points. And so let's go on to our case number 2. We have a 55-year-old who has Gleason 9, PSA 55, CT and bone scan negative, scheduled for an RRP, sees me in second opinion. We get a PSMA PET, and he's got diffuse nodal disease and 1 bone met. Germline and somatic, he's BRCA2, he was P10 proficient. So we had a number of different choices. So anybody who treat, again, this is a very robust 55-year-old, very active guy who wants to be very aggressive. So ADT alone, ADT plus NHT or 6 cycles of docetaxel, ADT plus NHT plus 6 cycles. Okay, how about an ADT and a PARP inhibitor? He's BRCA2. Well, a PARP inhibitor, unless you're doing a clinical trial like we're doing with triplet therapies, is only approved in metastatic CRPC after patients have had an NHT for olaparib, and then for rucaparib they have to have had an NHT plus chemotherapy. So it's not in this setting. He could have been a patient in our clinical trial because he was BRCA2 positive, but he wanted to be very aggressive. And again, he couldn't get into the trial because it was based on advanced imaging. It wasn't on conventional imaging, so he wouldn't be a candidate for those trials. So what he has elected to do is ADT plus docetaxel, and we did get the approval for darolutamide, even though it's not approved yet. Some of the insurance payers are looking at that, and we send them a copy of the New England Journal, and they look at that and they say, okay. Others, they're still stuck on ADT alone. But there are other companies. So this patient, it was approved. The patient that I just presented before, we offered him triple, and he wants to do triple therapy, but they denied darolutamide, so we're in the process of trying to get one of the other NHTs approved for him so we can give him triple therapy because he wants to be aggressive as well. This patient, Judd, in answer to your question, he's going to get consolidative treatment, and it's most likely going to be radiation, possibly cryo. He's been talking to Dave Crawford, and you could consider a prostatectomy as well. But this is a young guy who we're going to be very aggressive with. So I think that is the end of my presentation. Thank you very much, and thanks for your participation.
That was wonderful. And I failed to mention at the beginning, we had some other people come in. I just say it's great to be back in person. This is really, it's been a while, so we're really appreciative. We've got a great audience. Just by show of hands, how many people are from North America? How about South America? How about Europe? Asia? Australia? New Zealand? So we're pretty well covered. Antarctica? No, I guess not. So can we get my slides up, the Mal? And I'm going to give a very, I think this is it. I'm going to give a very brief, let's see. How did you get that to go forward, Larry? Is it this one? This one?
Is it not working? Yeah, there you go.
Okay, so it looks like we have some poll questions up, right? So we had some technical issues getting the pre-test questions before, so you should do pretty well on this because probably most of the questions are related to Dr. Karsh's talk. So,
Try to go back just so they can have the instructions on how to.
oh, I'm sorry.
Yes, you're fine. I think it's 2 slides back.
So log into pollev.com/AUA meetings 818. Or is the second bullet an alternate way?
I believe so. This is the first one I've done.
Text AUA meetings 818 to 22333 once to log in. So if you go 22333 and then AUA meetings 818, that'll get you to the login. And to our audience, virtual audience, are they able to do this as well? Okay, so those who are on the virtual today, again, glad you're here. You're able to participate with this poll, pollev.com/AUA meetings 818, or text 22333 and put in AUA meetings 818. Does everyone have that before we move on? So So this is, I guess, will they see this on the screen?
Yes, go ahead and go to question 1.
Okay, let's go to question 1. So in M1, hormone-sensitive prostate cancer, which of the listed agents is not approved for use with traditional ADT? Abiraterone acetate, ketoconazole, apalutamide, enzalutamide, or docetaxel? Now, if anybody gets this wrong, after Dr. Karsh's outstanding talk, putting pressure on you there, right?
We'll see who was paying attention, right?
So, do I have to click forward? They're not going to get we're not going to give the answers right now, correct? I don't think. Let's. Okay, so this is pre-test number 2 regarding high-volume M1 hormone-sensitive prostate cancer. Which statement is false? ADT plus apalutamide is appropriate. ADT plus enzalutamide is appropriate. Urology referral to GU Medical Oncology is appropriate. ADT plus docetaxel is not appropriate. Which statement is false? Okay, we'll move on. So there's the instructions again at the top. Pretest 3, in non-metastatic castrate-resistant prostate cancer, which is what I'm going to go over briefly next, which statement is false? There are 3 FDA-approved agents to extend overall survival for this category. Enzalutamide plus apalutamide are both FDA-approved for both non-metastatic and M1 hormone-sensitive. The baseline PSA has to be 2.0 or higher, and patients had to demonstrate a castrate testosterone level to qualify for use of these novel oral agents in Spartan, Aramis, and Prosper. Or D, a PSA doubling time less than 12 months was an inclusion criteria for studies of oral agents approved in non-metastatic CRPC. So which of those 4 is false? Okay, we'll move to the next one. Regarding the management of non-metastatic CRPC with oral novel androgen blocker agents, which statement is false? Darolutamide is not contraindicated in patients who have a history of seizure. The most common side effect of enzalutamide is skin rash. Hypothyroidism is a possible side effect of apalutamide, and darolutamide dosing is BID. Which of these 4 statements is false? And then finally, this is the last question. When considering treatments for metastatic castrate-resistant prostate cancer, which statement is true? We haven't done this talk yet. Dr. Morgan is going to do this. Pembrolizumab is FDA approved for treatment of patients with PALB2, CHEK2, and CDK12 alterations. Common side effects of olaparib are hair loss and hypertension. 177 lutetium PSMA 617 is FDA approved for patients with disease progression after treatment with docetaxel and an AR targeted treatment. And radium-223 is only associated with pain relief but does not have a survival benefit. Which one of those statements is true? Okay, so what I'm going to do, I'm going to try to go through this very briefly. I'm going to give a talk on, no, this is the, let me go through. I think they have your, this is Dr. Karsh's talk, so we need to go to the M0. While we're waiting for those slides to go up, how many people in the audience have actually seen or treated a patient with M0 CRPC in the last 2 months? A few. So that's very interesting because I think the key teaching point on this talk is that some people think that this disease state is going to go away and that it's maybe somewhat irrelevant. So, but nevertheless, I'm going to go through this. We have, with regard to this non-metastatic CRPC, we started talking about this in 2018 when the first agent got approved. And now we have 3 non-steroidal oral anti-androgens that are FDA approved since February of 2018. So, and Dr. Karsh covered those drugs in the metastatic setting. Here we're moving it forward one step to non-metastatic CRPC. These patients had traditionally been in urology practices, at least in the United States, as a urologist had given hormone therapy for biochemical recurrence, and these guys were in the practices. And so the biggest challenge we have faced since 2018 is identifying these patients in practices because they seem to sometimes get overlooked. Even if you don't manage CRPC, 2 of these 3 agents are now also approved for M1, as you heard about. So again, it's relevant for all urologists because we see metastatic disease. So the oral agents are safe. They all extend metastasis-free and now overall survival. 2 years without metastasis is clinically meaningful. So again, it's more of a problem with whether the disease state exists or not. The agents are very effective. So if you do identify one of these patients and you give one of these drugs, you can delay metastasis by 2 years and they all show overall survival. You could argue that 2 years without having to switch physicians is good for patients, or at least helpful to their quality of life. And again, for the majority of these men, the 2 years or more quality is quality of life, not just life, because their quality of life stays pretty good. And the drugs are really straightforward with proper education. What is it? It's non-metastatic disease, but PSA is rising on continuous ADT with a castrate T and no mets on standard imaging. Remember, all these agents were approved prior to the era of PET scans. So these trials were done with standard bone scans and CAT scans. And the 3 FDA-approved drugs we already heard about, APA, Enza, and darolutamide, all improve survival. They're if you look at the literature, some people refer to these as third generation nonsteroidal oral anti-androgens. Some people say they're second generation. But as we know, their forefathers were flutamide, bicalutamide, and nilutamide. And those did not improve survival, but these do. Key side effects include falls, fractures, rare seizures, rash, chemical hypothyroidism. But none of the drugs, when the FDA approved them, require special monitoring. So you have to be aware of these things, but unlike some of the drugs in the past, you're not mandated to get liver function testing, or you're not mandated to get thyroid testing. I'm going to skip this for the sake of time. The key teaching point, this was a gentleman who did fit the criteria and had a rising PSA, and eventually his PSA rose, and he went on one of these agents. So he currently had a PSA of 2.8. He had a castrate serum testosterone. He underwent restaging with a bone scan in the CT, which was negative for metastasis. And so he fit the criteria for non-metastatic CRPC and went on one of the agents. Again, rising PSA in the setting of a castrate testosterone level, and no tumors seen on traditional imaging of a bone scan and a CT. Now, in the clinical trials, the doubling time had to be less than 10 months. So on that pre-test question, the 12 months was incorrect. And maybe it was a little bit of a trick question, but or persnickety, but it asked they had to be less than 10 months to get on the trial. When the FDA approved these agents, they never put that in the label. So as a clinician, you don't have to prove that the patient has a doubling time less than 10 months to use these agents. The 3 trials were Spartan with apalutamide, Prosper with enzalutamide, and Aramis with darolutamide. Again, the first one out of the gate was apalutamide in February of 2018. In fact, on Valentine's Day of 2018. Then July of 18 was Enza, and then in July of 19 was Dara. And these were just the apalutamide first author was Matt Smith. Enzalutamide first author was Maha Hussein. And darolutamide was Karim Fizazi. So these were all published in the New England Journal of Medicine. This is a busy slide. What's the key teaching point? The trials were essentially identical as far as their design. 2-to-1 randomization, similar numbers of patients, similar stratification, all had to have a doubling time less than 10 months, all had to have a PSA greater than 2. And so the only slight difference is, some of them excluded patients with a seizure disorder. Some of them had some slight differences in cardiovascular toxicity, allowing those patients on board. And they all showed a benefit in this metastasis-free survival, give or take, of about 2 years. And they all showed an overall survival benefit. So they're all effective drugs in this class. They all have their unique side effects or issues. Now, enzalutamide and apalutamide do cross the blood-brain barrier, so potentially a little more fatigue, a little more slight higher risk of seizure. Enza has a little bit higher rate of seizures than APA. Darolutamide does not cross the blood-brain barrier to any significant degree, so there's some differences there. These are shown on the slide, and the one side effect of apalutamide is the rash that occurs in mild rash in up to 20 to 25% of patients, but any sort of rash that would be a game changer that would require you to stop the drug is pretty darn low, in the order of maybe 5 to 6%. Most of the time it's self-limited. Again, ASCO update 2020, they showed survival benefit, and so on all 3, so again, they've mirrored each other. And then what's, though, the key discussion in 2022? So now we have PET scan. So the question is that how do you handle a PET scan finding in the setting of wanting to use these agents? And so, and also, how do you decide between apalutamide, enzalutamide, darolutamide? They're all, great drugs, wonderful that we have in our toolboxes, but they're very similar. And so we have to make those decisions. What I'd like to do is kind of just open it up to Dr. Karsh and Dr. Morgans, just to see how you manage a patient like this. Specifically now, Larry, if you have a PET scan, do you just kind of ignore it in the set if the guy has a negative bone scan or a CT? how do you handle it?
Well, I showed you that case where we acted on a PET CT, PSMA. So I tend to think that if these patients have positive scans, and we're getting more and more of them now, then I'm going to make treatment decisions based on those scans.
So basically, you would use these agents, but it would definitely be an intensification with either a triplet therapy or with SBRT or something.
Correct.
Dr. Morgan?
Yeah, thank you. I think this is such a clinically important question because we are increasingly using these scans, whether we're in the hormone-sensitive biochemical recurrent state or whether we're in the M0 CRPC state as we are in here. I would encourage all of us, because we're using these scans, that we don't back off of the systemic treatment intensification that has clear survival benefit. So the 3 drugs that Dr. Moll just showed us, when we add those to ADT, we not only delay metastasis for 2 years, we also improve overall survival, even though the majority of patients in the control arms of all of these trials got the drug eventually. So it's early versus delayed intensification. The earlier intensification, we're prolonging survival. So I use the PSMA PET scans in this setting to add on things like SBRT, but I don't use it to say, oh, I'm not going to intensify my therapy if I have a negative PSMA PET scan. So I just really want to emphasize that.
Very good point. And the other thing about this, if you're dealing with an M0 CRPC that's going to have a negative bone scan and a CT, but as a positive PET scan, in all likelihood, that's going to be minimal, that's going to be low volume. I can't think of a scenario where you'd have a negative bone scan and a negative CT where you would call the PET. So in other words, I guess in this setting, it would be intensification, but you probably wouldn't be adding docetaxel at this point, correct?
I would not. I actually, so docetaxel in my practice is for patients with high volume hormone-sensitive disease or MCRPC defined by conventional imaging, because that's how the phase 3 trials that led to the approval actually were designed. So I use PSMA PET to help me understand if I might be able to do SBRT to oligometastatic disease, or in this case, very low volume metastatic disease. But I wouldn't use it, especially in the hormone sensitive setting, really to define high volume disease. And one other caveat, point sort of building on what you mentioned, 98% of patients in a nice study done by Fendler and colleagues who had M0 CRPC, as was defined in the Spartan trial, which again, as we heard, basically they're all defined the same way. Actually, 98% of them had some identifiable PSMA PET avid lesion. So most of the patients that fall into this category are going to have something on their PSMA PET. We just, I think, need to remember that they also could be helped by intensifying their systemic therapy.
And I think that's a very important point.
That's the
Right here. That was planned.
That's good. No, that's it's all good. So again, the key teaching point, as Dr. Morgan said, is that if you do want to, especially I would think the PSMA arguably is a little bit more sensitive, although let me just go back one slide. I wanted to get that one on when she said that. So here's what here are all the stuff that's coming down the pike. 2 new FDA approvals, PSMA PET gallium-68 or F18. We had the choline PET 11 or F18 approved at Mayo Clinic, fluciclovine, which has been approved, FDG PET. So there's a lot, and the bone-only sodium fluoride F18 is kind of fallen out. We're not really using that anymore, to my knowledge. But these are just some of the things that, and they're going to be more. So, but this is probably the money slide of this particular talk that's new in 2022 compared to when we gave this in 2018, that this disease state, it's still important to learn about it, but it's changed because of imaging. So PET scanning, now here's what I would say though, PET scanning is not required before the use of these 3 oral agents. If you don't have access to a PET scan where you're practicing, certainly doesn't preclude you. As Dr. Morgan said, these 3 agents are all adding early use, or adding survival, they're adding metastasis-free survival. The PET findings would not preclude the use of these agents as long as the traditional imaging is negative. However, for healthy men with a longer life expectancy, it's certainly reasonable to combine these agents with SBRT, although and I'm not 100% I'm even correct on this. I don't believe there's any level 1 evidence at this point, although, is that?
You're right.
Okay, I didn't think there's any level 1 evidence. We're doing it, and we believe we're benefiting patients, but we're not certain that the intensification with SBRT will lead to an improved survival. The systemic therapy does. So I just wanted to go through that quickly. I had the hardest and the easiest job because that part was not very new, but the PET scanning was fairly new. So we're going to move right on, and I would like to introduce Dr. Morgans, who's going to cover metastatic castrate-resistant prostate cancer.
Well, thank you, and thank you guys for sticking around. Lots of ground has been covered. So we'll go into metastatic CRPC. And here's an outline of what we're going to discuss. So first, general principles, just to remind us as a multidisciplinary team, kind of the backbone of how we consider MCRPC and some of the newer advents of germline and somatic genetic testing. Then I'll talk about specific treatments, so PARP inhibitors, and focus on those and some updates in that area. Moving on to pembrolizumab, and then lutetium, one of our newest approvals. We'll talk about supportive care, particularly bone health, which, as we heard earlier from Dr. Karsh, is different than it is in the hormone-sensitive setting, where we're really focusing on fragility fractures, osteoporotic-related fractures. In that setting, here we're talking about skeletal-related events, and then we'll end. So the general principles of MCRPC are probably things that you have heard and thought about before, but I'd just like to remind us of these basic tenets. This is the NCCN guideline, the most updated version prior to slide entry for review by the AUA. So it may have changed even since I submitted this. But as you can see here, it is very complicated, but it is also very much devoted to understanding what a patient's received before as we're trying to figure out what a patient should receive now. And that's because, particularly when we're talking about androgen receptor targeted agents, the resistance methods of the cancer cells are actually very similar. Resistance to abiraterone often confers resistance to enzalutamide, for example. So we have to think about what a patient's received before when we're trying to think about where a patient should go next. This is a schematic of how I think about treatments for MCRPC, because for me the colors and the organization is a little bit easier to understand. On the left we can see some of the agents that we can use in the metastatic hormone-sensitive setting, and then each line that we move through the MCRPC setting, I try to change colors. And so that, I think, helps me think through, how do I want to work on this? And new additions to this schematic include the PARP inhibitors, olaparib and rucaparib, as well as pembrolizumab. And these are for specific populations. And I will be adding lutetium on here soon enough. Actually, I did add it, so good for me. But it is on there on the radiopharmaceuticals on green. So thinking about these general principles, clinical factors are still absolutely key. So again, what were the prior therapies that these patients have received? Which options are actually available for my patients in my practice location? And this is going to be increasingly important as we're thinking about integrating lutetium into our practices, because this requires multidisciplinary care, both for patient selection using PSMA PET scans, and then, of course, getting patients to either nuclear medicine or radiation oncology where they can get the treatment. Who's going to follow that patient in the toxicities that may occur during therapy? What kind of supportive care do we need to provide? Who's going to provide that? So these are going to be really important, and what's available in your location is going to be critical in choosing this treatment and others. Are there visceral metastases? Of course, important for treatment with radium versus bone-only metastases. Is the patient a candidate for chemotherapy? So can I include that on my list of options? Is the patient developing small cell differentiation, and most importantly, or neuroendocrine differentiation? And small cell differentiation is the most important there, because that is going to actually lead us to want to use certain chemotherapy combinations that we would not normally use in a prostate adenocarcinoma. Are there targetable DNA repair defect mutations or MSI high status for some of our targeted therapies? And are there clinical trial options? Always a critical point. So just to hammer home one of the points about novel mechanisms of resistance, I really like this study. It's a number of years old, but it was a study looking at biopsies in patients who had multiple areas of metastatic disease, and then looking at the genetics of the different sites of metastatic disease to look for mechanisms of resistance and how they may have traveled actually between the primary prostate and metastatic sites, or between different metastatic sites, and how they moved around and were actually shared between these metastatic sites. It's actually, I think, a reminder of how smart these little cells are and how they can transfer these mechanisms of resistance all around the body. So it's very scary, but we have to be smart about it, obviously. Changing mechanism of action to deal with this concept, I think, is really, really important. So, thinking about this other general principle, sequencing androgen receptor targeted agents is usually minimally effective. And here's some data to suggest that. There are multiple studies, not just the ones listed in this table, that demonstrate that there's a very low PSA response, as well as a very low median PFS benefit and OS benefit when we're sequencing AR targeted agent versus after AR targeted agent. Here, I think, is one of the more important studies that led to another piece of data that suggested this. This is the CARD trial, which was looking at a more advanced metastatic CRPC setting for third-line treatment. Patients had had progression of disease after docetaxel, as well as an AR-targeted agent, and they were randomized to treatment with cabazitaxel versus the alternate AR-targeted agent. We can see in the control arm of this, where they had that alternate AR-targeted agent, that there's an extremely short median PFS of about 2.7 months for that second AR-targeted agent. This is a randomized trial. These patients didn't necessarily go AR-targeted agent to AR-targeted agent. Some of them were sandwiched around docetaxel, so AR, doci, and then the second AR. It didn't make a difference. There was a very minimal to no PFS benefit to that second AR-targeted agent. Profound similarly showed this concept. So again, this is a DNA repair defect selected group of patients with MCRPC who had been exposed to an AR-targeted agent, previously had progression of disease, as well as docetaxel chemotherapy in many situations. They were randomized to treatment with olaparib versus that alternate AR-targeted agent. The median PFS here on the control arm was 3.5 months, basically the time to the first scan. So this AR-targeted agent back-to-back, or even sandwiched around docetaxel, does not work for the majority of patients. So another general principle is that genetic testing should be offered to patients, and I think we've heard this at other venues during this meeting so far. This is something that is endorsed by the AUA, and absolutely covers patients with MCRPC, as well as any metastatic patient. And this is the NCCN guideline that endorses the same thing. Any patient with metastatic disease should undergo germline testing. And if that hasn't happened by the time the patient has developed MCRPC, germline testing should be performed. About half of the alterations that we can act on in the DNA repair defect pathway are identified in the germline setting. About half are identified in the somatic testing that we should also be doing. So in the MCRPC setting, germline and somatic testing should be performed. And here we can see some of the genes that should be included in the somatic testing as we're doing that. It's really nice that they've actually given us a list, because there are multiple panels that are out there for somatic testing as well as for germline testing. We just need to make sure that the genes that might drive our therapeutic decisions are included in our panel. So they're listed here: BRCA1, BRCA2, ATM, PALB2, and others. So as we're choosing our germline and our somatic tests, just make sure that the test has the genes that you're interested in understanding. And of course, this is because there have been multiple studies to show the prevalence in MCRPC of the DNA repair defect pathway alterations that can be targeted with things like olaparib. 23% approximately of patients with MCRPC will have these DNA repair defect alterations. And as the disease progresses, this actually, the frequency increases because we're selecting for these more aggressive clones. We also know that, as I said earlier, any patient with metastatic hormone-sensitive disease and beyond should undergo germline testing, and that's because in the metastatic setting, including hormone-sensitive and castration-resistant, the prevalence is approximately 11.8%. So
25% included both somatic and germline.
Yes. So thinking about some recent therapeutic advances, do you think, in the interest of time, Judge, should we move through this? Should we? We have time? Okay. All right, great. So Mr. GB is a 68-year-old gentleman with a history of hypertension, hyperlipidemia, and prostate cancer diagnosed about 4 years ago. He had localized disease diagnosed initially with a PSA of 6.9 and a Gleason 4+4 disease, PT3B N0 M0. He underwent that prostatectomy and adjuvant radiation because of his PT3B disease. Family history was notable because his mother died of ovarian cancer at 38 years old. He had a rising PSA and a CT chest with new lung metastases and a bone scan with numerous metastatic sites in the pelvis and vertebral bodies shortly thereafter. He was started on ADT and docetaxel for metastatic hormone-sensitive disease. He then developed metastatic CRPC when his PSA rose to 15. He had a CT with new bone metastases, enlarging pelvic lymph nodes, and the largest was 3.4 centimeters. What are the appropriate next steps in the management of this patient? He has been treated with docetaxel already for metastatic hormone-sensitive disease. Should we get a PSMA PET to evaluate for treatment with lutetium? Can I see a show of hands? Okay, a couple, thank you. Bone lesion biopsy to send for next generation sequencing and chemotherapy sensitivity assays. Anybody? Good, because I'm not aware of any chemotherapy sensitivity assays that are actually going to be helpful, so good. It would be amazing if we had them.
I heard something about GP53 mutations may possibly give you an indication. Is there anything to that?
So, so there are some. So, just a question about TP53 mutations. Do they help when we're choosing chemotherapy? So sometimes we think about PTEN, RB, and P53. If we have 2 out of 3 of those, that patient may be more susceptible to a carbo-cabazitaxel combination chemotherapy. At least that's what I think of. And sometimes some of these alterations suggest a more aggressive cancer that may be more chemoreceptive or responsive. So good, very good point. Moving on to number 3 here. Germline and somatic genetic testing for DNA repair defect mutations and MSI high status should be performed. Anybody? A couple, smattering. Okay, very nice, good. Initiate denosumab, 60 milligrams sub-Q Q6 to prevent fragility fractures. Anybody? All right, so the right answer here is germline and somatic genetic testing. The reason the last one's wrong is because the dose is incorrect for MCRPC, and we're not trying to prevent fragility fractures here. We're trying to prevent skeletal-related events. So good work. Mr. GB underwent germline and somatic mutation testing because you decided to get it. He was diagnosed with a VUS and ATM in tissue testing and in germline testing. He was started treatment with abiraterone 1,000 milligrams daily and prednisone 5 BID and denosumab 120 sub-Q monthly. That's the MCRPC dose. His PSA, though, eventually rose to 45. He developed back pain in areas of metastatic disease, and a CT showed progression of bone metastases and enlarging lung metastases. Now, what are the next most appropriate steps?
The VUS was a variant of unknown significance. It was
Yes.
not pathogenic.
Yes. So to confirm, the ATM variant of uncertain significance was not pathogenic. It was reported as a VUS. So the more of this germline testing that you do, the more you will see these VUSs. If you're very curious, you can actually type them into some of the NCI-supported databases where you can actually look up if someone has defined them as being pathogenic or not, but usually 95% of the time or more, they're truly going to be benign. Even if you look them up, you may find that they're benign. They're just not updated in the particular testing platform where they're still reporting them as a VUS. But it is very uncommon that a VUS is considered pathogenic. Although something to watch out for, and the companies often will report to you, if they make a change from a VUS to a pathogenic, they'll often report it to whoever's ordered the test so that you can report that to the
That's
patient.
what we're concerned about. Are they going to really report that to us? Do we have to keep following up for that patient? And, that's the
They say
big
they're going to
question.
report it. And my
Yes.
genetic counselors have told me that they report it, so I hope they report it, because that's a lot.
Yeah.
Giving the report to the patient also helps to promote advocacy for that individual and empower that patient to also continue to look over time. 20 years down the road, maybe they'll find something, but giving the report to the patient and potentially the family can be helpful. So for this patient who's progressed on docetaxel and abiraterone, has a VUS, but nothing that's clearly identified as a pathogenic DNA repair defect alteration, what is the most appropriate next step for this patient? Who thinks PSMA PET to evaluate for treatment with lutetium? A smattering. Thank you. Initiate treatment with olaparib for the ATM-VUS mutation identified on germline and somatic testing. Good. We kind of gave you the answer on that one, so good. Initiate treatment with pembrolizumab for ATM-VUS mutation identified on germline and somatic testing. Yeah, we already talked about VUSs, but treatment with radium-223 for symptomatic bone metastases. Okay, so the answer is answer number 1 or dot 1. And the reason it's not radium is because this patient does have soft tissue disease, so there are some nodes involved. And pembrolizumab does not go after ATM, or that's not a pair. All right, so let's talk about PARP inhibitors. Olaparib was tested in the phase 3 PROfound trial, and this included patients who had metastatic castration-resistant prostate cancer who were identified as having one of a number of DNA repair defect alterations. All patients had had progression on an AR-targeted agent, most on docetaxel and some on docetaxel, cabazitaxel, and both AR-targeted agents, so some were quite heavily pretreated. They were divided into 2 cohorts, with cohort A having the primary endpoint sort of relying on that cohort, which is the cohort of BRCA1, BRCA2, and ATM patients. Cohort B was a bit more of a grab bag of the less common DNA repair defect alterations. All patients were randomized 2-1 to receive olaparib versus the alternate AR-targeted agent. And I think that we already saw how the alternate AR-targeted agent did when I showed you the control arm previously. The primary outcome was progression-free survival in cohort A. So here is the overall cohort PROfound trial PFS, where you can see that olaparib was clearly associated with an improvement in PFS as opposed to the alternate AR-targeted agent. And here we can see that overall survival was also improved in cohort A, BRCA1, BRCA2, and ATM alterations in patients who received olaparib versus that alternate AR-targeted agent. This did not meet statistical significance in the overall population, which included those other alterations. Rucaparib is also approved for the treatment of MCRPC. This was tested in the phase 2 Triton-2 trial. This included patients, again, with DNA repair defect alterations, a very similar group as to those included in the PROfound trial. All patients had had progression of disease on an AR-targeted agent and on docetaxel. All had had to be exposed to docetaxel, and they had progression of MCRPC. They were followed for a primary endpoint of response rate. On the left, we can see a really nice waterfall plot demonstrating the RECIST response to treatment with rucaparib. So a very nice response in terms of decrease of lesion size. And on the right, we have PSA responses as well. And these are just for patients treated on this trial with BRCA1 and BRCA2. So these trials led to the FDA approvals, which include rucaparib, which is approved for patients with BRCA1 or BRCA2 alterations who have had progression of disease after an AR-targeted agent and docetaxel in the MCRPC setting. Olaparib is approved for patients who had any of the alterations included in the PROfound trial after progression of disease on an AR-targeted agent. They do not have to have prior exposure to docetaxel. So these are slightly different approvals, but both approved in the MCRPC setting. So just to briefly go through pembrolizumab.
Can I just ask a practical?
Yeah, please.
So how do you make, from a practical standpoint, how do you make a determination between when you prescribe one or the other?
So I use disease state, so whether the patient's been exposed to docetaxel or not. And in many cases, patients are asking for this before docetaxel. And so I'm often using olaparib because of the disease setting. It also has a broader array of alterations. But I think either is a completely reasonable option. And some providers may have a lot more experience with rucaparib, so may feel more comfortable using that agent.
You know, it kind of comes down to whether you do the high or low volume definition when you're talking about triplet therapies.
Yes.
I don't know that I have seen a lot of, you know, in the PROfound trial, everything else other than BRCA1, 2, and even they had ATM. I'm not sure that I'm getting some real good results. I think when they have BRCA1 and 2, I see that they respond the best. I mean, is that what you see in your practice?
So I think Dr. Karsh is bringing up such a good point that these alterations are not all created equal, and they don't all respond equivalently to these PARP inhibitors. And I think there's a lot of work to still be done. As we heard earlier, ATM is actually now a population not included in Triton-3, and this is because we may not be seeing so pronounced responses in that setting. BRCA2 patients are both the most commonly seen in prostate cancer, but also probably the most responsive to these drugs. And another group that's not always considered, but seems to be relatively well responding is PALB-B2. So also keep that one in mind. But I think we are really still figuring this out. Just because a drug is approved for all of these alterations, like olaparib, does not mean you necessarily will see blockbuster responses on a lot of those alterations.
Do you see practical differences in toxicity between the two drugs? Does that ever make a determination on your decision?
I have not. They seem to be, the side effect profiles really seem quite consistent with the class effects of having some cytopenias, maybe some fatigue, a little GI upset with any oral agent, but I have not seen that there have been pronounced differences. Although, Dr. Karsh, do you have a similar or different experience?
Well, you know, a lot of my patients, they get to that point, have not seen docetaxel at that point, and so it kind of makes it more difficult to use rucaparib. But if they have, then, you know, you could consider it, but, you know, that's the difference between those two.
Agreed. Well, thank you for that great conversation. So moving on to pembrolizumab, which has been approved, as we also heard earlier, for any patient who has MSI high status, for patients who have TMB, tumor mutational burden, greater than 10, and patients who have MSH and MLH mutations affiliated with Lynch syndrome, MSH2 and MSH6 being the most common in prostate cancer. This is a really interesting approval that's sort of pan-tumor type in solid tumor and really based on the genetic testing. So we have to get the genetic test to understand if we can use it. So in terms of MSI high metastatic CRPC, we do see these patients in our practice, but they are few and far between. It's approximately 2 to 3% of the CRPC population. But if we don't look, we won't find them. For those patients who do have MSI high status, it can be incredibly effective to treat them with pembrolizumab in the MCRPC setting, and these CTs just demonstrate some really, actually quite beautiful responses to treatment with pembrolizumab. Lutetium PSMA 617 is also a new approval. This is a very recent approval. And this is based on the VISION study, which was a phase 3 study of lutetium PSMA 617. So this included patients who had had previous treatment and progression of disease on an AR-targeted agent, as well as docetaxel chemotherapy. All patients had MCRPC. They were randomized 2-to-1 to treatment with lutetium plus the best supportive treatment or supportive option, which could have been an AR-targeted agent in combination with lutetium or prednisone or another steroid or even a pain medication versus the best supportive or standard of care option alone, and patients were followed for a PFS and OS combined endpoint. So here we see the overall survival and radiographic progression-free survival alternate primary endpoints with OS on the left and radiographic progression-free survival on the right. We did see about a 4.5-month improvement in overall survival for the treatment of this very heavily pretreated MCRPC population with lutetium versus the best standard of care option. And here we can see the PFS is even a little bit longer. The safety data suggests that the primary concerns here are going to be some fatigue as well as cytopenias. So it is important to keep an eye on the CBC and potentially support patients with transfusions if that does become necessary. But generally, this treatment has been relatively well tolerated. Dry mouth is another very specific side effect for some of these radiopharmaceuticals that are targeting PSMA that we should all be aware of. And finally, just to go through supportive care very briefly, so supportive care, as I said, in the MCRPC setting is to prevent skeletal-related events. It is under-recognized and underappreciated. This was identified as being a pretty interesting and clear problem. In the ERA 223 trial, in which patients with MCRPC were treated with abiraterone plus radium versus abiraterone alone and followed for a primary endpoint of symptomatic skeletal events, because we thought that the combination of abiraterone and radium might delay the time to symptomatic skeletal event. What we saw, however, is that those patients in the combination arm had a substantially increased risk of fracture. 40% of the excess fractures in that arm occurred in the first 6 months. And actually, we saw a pretty substantial fracture rate in the abiraterone alone arm. So these are all MCRPC patients. They all qualified for treatment with monthly denosumab or zoledronic acid. We clearly were not giving it to them, though. And when this was identified, a very similarly designed trial, the Peace 3 trial that was proceeding in patients with MCRPC who were randomized to treatment with enzalutamide versus enzalutamide plus radium, became very aware and made a quick call to try to prevent this from happening in their study as well. What they did was actually send out a safety letter to tell everyone, get your patients on a bone protective agent per standard of care, please, now. And before the exposure to the bone protective agent and that safety letter on the right, you can see a pretty substantial level of fracture in the combination enzalutamide and radium arm, and even a pretty significant level of fracture in enzalutamide alone arm. But after exposure to the bone protective agent, sort of the left side of this graph, those rates went to 0. So using bone protective agents is standard of care, has been for a long time, and we need to remember to do it in metastatic CRPC.
You know, it is amazing that in all of these clinical trials that we've done, probably the use of bone protective agents has been under 10% for
Yes.
the patients that are enrolling in the trials.
Yes,
And that was the key thing that they found with the ERA trial. So,
yes.
you know,
And these are patients on clinical trial, so they're seeing
Yes.
really, these are doctors who are
Yeah.
good enough to be opening these clinical trials, or organized enough, I should say, in their systems to be opening these clinical trials, and we're forgetting it. And so we just need to get on the ball. So treatment of men with MCRPC continues to evolve rapidly. General principles continue to hold true. Use of a second or targeted agent after the first has failed is generally not going to be effective for our patients, not in a meaningful way, not in a prolonged way. Germline and somatic genetic testing are standard of care in MCRPC. If we haven't done it before, we should do it now and use it to potentially guide family counseling and treatment decision making. Genetic testing can identify DNA repair defect mutations that can be targeted by PARP inhibitors or MSI high status that can be treated with pembrolizumab. Lutetium PSMA 617 is an option after progression of disease on docetaxel and an AR-targeted agent. Patients do have to be selected with a PSMA PET for treatment with lutetium, and at this point at least, the label still says that it has to be a gallium PSMA PET, so everyone should be aware of that. NCCN guidelines were actually just published to say that a DCF-PYL PSMA PET could also be an option, but that's not what the label says. We're still waiting to see what will be covered by insurance. And
I think that's very interesting. I mean, because that's what we're trying to struggle with, because we don't have gallium available in our neighborhood.
yes.
So are these patients going to not get lutetium? And
I hope
You
not.
know,
I
yeah.
hope not. So I think that's one of the reasons that the NCCN guidelines
Yeah.
came down clearly that these we should be agnostic to the PSMA PET
Right.
tracer to allow patients access. At this point, there's actually a hold on lutetium because
Right.
of manufacturing concerns, which we hope and expect to be resolved within 4 to 6 weeks. But these are challenges that we as a field are trying to work out. How do we get these drugs to patients?
You know, and I'm glad we have this, because we have so many patients now that are, living longer because of all these other therapies, and then we're running out.
Yes.
And it's nice to have something else if we don't have a clinical trial for those patients.
I agree. And remember bone health, so we keep those patients alive to get their other treatments. I hope that wasn't thunder.
I think it was.
That's concerning. Okay.
Let's hope the roof doesn't leak.
Yes.
Oh, we're not on the top floor anyway.
Yes.
I have a question about, I know you had it in your beginning slide. I thought you did a beautiful job of the colors and moving through the sequence, and you had Sipuleucel T listed, and I was just curious, where does that fit in this? Because obviously it was FDA approved in 2010 before any of this other stuff, and does the survival data from the quartile data or even the PROCEED registry resonate at all in light of the other stuff?
I think it does. And I think it certainly does after the triplet combination has come out. So we may have patients who are progressing to MCRPC after the maintenance AR-targeted agent, post-docetaxel, who are relatively asymptomatic or low symptom burden, don't necessarily have liver metastases, because those are reasons not to use CYP-T. And I think that CRPC could absolutely fit into that space. That's where I commonly think about it, in that first-line MCRPC setting. And I do have to say, I try to sneak it in any patient who has a low symptom burden. And I know that I'm, in most patients, going to be moving to my next treatment relatively soon. But some, I've had no disease progression for over a year for some guys. And you never know who it's going to be.
I agree with you. I think that's a great point. We try to get it in. It's only going to be a 5-week treatment.
Yeah.
And you can get it in and then start the other treatment right after that.
Yes.
So, and I know in our neighborhood, a lot of the oncologists don't believe in CRPC.
Yeah.
But I'm a believer.
I believe
At
in
the right
level 1
time.
evidence. It's a phase 3 trial with survival benefits.
Yeah.
So it's hard to disagree with that.
I have a question about the CARD trial. So if we have a patient that is progressing on an NHT, but they never saw docetaxel, would you consider giving them cabazitaxel? I mean, it's not, you
Yeah.
can't do it before they've had docetaxel, and do you think that they tolerate cabazitaxel better?
These are great questions for a multidisciplinary team to think about, I think. So, so you can sometimes get it. You can always appeal to insurance, and there are a couple reasons why you might want to do it. So, especially when you give cabazitaxel at the 20 milligram per meter squared dose, you actually may have a little less fatigue, fewer nail changes, maybe better tolerability, essentially, than docetaxel. And this was tested in the first TANA trial, where they looked at different doses of cabazitaxel versus docetaxel, and actually looked like the safety profile and the quality of life was a little bit better, maybe, in the cabazitaxel 20 milligrams per meter squared. Neuropathy also, very importantly, better. So if you have a patient who has pre-existing neuropathy, for example, you could make an argument to use cabazitaxel prior to docetaxel, and I've been able to get that approved in that setting, and people tolerate it well. The concern, a medical oncologist is always planning for a rainy day, so the concern is, if you use up cabazitaxel, then, what are you going to go to? Now we actually have a lot more options. So if that's something that's of concern for your patient, keeping the patient's neuropathy well now is probably more important than, saving the cabazitaxel for the future.
I found that patients do tolerate it better than they do docetaxel because of that
Yes.
as well. So.
Yeah.
We want to open it up for other questions. So we're I want to thank Dr. Morgans and Dr. Karsh for outstanding talks. And it's hard to imagine how many advances we've had since this course started 10 years ago. I mean, we didn't have much to talk about 10 years ago. Now we have a lot to talk about. But questions from the floor, anybody comments from other countries on experiences you've had? We have about 15 minutes left. If anyone has questions, we'd love to hear your comments.
And please come up to the microphone.
Yep, because this is we're on
live stream.
we're on live screen, so you're on TV.
I like to make about the triple treatment. If you have a patient with a sensitive hormone metastatic prostate cancer, and the treatment is the triple treatment, and this guy progresses, and the genetic testings are negative. And I heard that lutetium is not available right now in US because of the problem with with Pfizer. What is your next step?
So just the question was, so you have I believe, metastatic hormone-sensitive prostate cancer. You pulled the trigger for the triple therapy, and then it fails. So maybe, since you gave that, you started with that, maybe start with Larry to answer that question.
Well, I think that I would, first of all, consider a trial if we have one available. If it fails, they now become metastatic castration resistant. It depends on whether or not they're symptomatic or not, but I think Dr. Morgan's talked about maybe trying to get CRPC in there. And I don't know if we have that, you have that available, because I know it's not available in Europe, but that would be one consideration. I think that you could, and you should do genetic testing to make sure that you have not missed something like an HRR mutation where you could possibly give them a PARP inhibitor. You may want to consider going on to, would you use cabazitaxel at that
Yeah.
point?
Cabazitaxel or radium, or once lutetium's available, if you have a PSMA PET positive disease, you could use lutetium. So there still are options.
Yeah, I think it
Sorry.
depends on how long it took. The question is, would we
repeat the question,
re-challenge? Would we re-challenge them with docetaxel?
Yeah.
And I think it would depend on how long it's been since they were on docetaxel. If they progressed within maybe a year, I think that they probably won't respond to it.
Agreed.
But if it's a longer period of time, do you agree that you would
Absolutely.
re-challenge them?
Yeah, and it can be really effective for some patients to re-challenge, especially if it's been a few years that they've been on that AR-targeted agent. It's not that they failed docetaxel, to your point. It's that we gave them a prescribed duration. They completed the course, and so they very well may be sensitive to retreatment.
You know, one kind of question that comes up, if related to Dr. Karsh's talk, if you go back to the original when ADT was what we had, Dr. Hussein, who was mentioned earlier, had a really important paper that looked at 7-month PSA. So if you gave a guy metastatic prostate cancer, gave the guy ADT, and if his PSA dropped to 0.2 or less, essentially undetectable, we had a really good survival. 0.2 to 4.0 was okay, but if he nadered above 4, it was really bad. So now this new, and I just saw there's some new data with, I think, one of the, possibly ENZA or APA, that mirrors that with the novel therapy. So have you guys had any experience with pulling the trigger earlier for a suboptimal PSA nadir when you're dealing with the new double or triple therapy?
Well, I don't make decisions on PSA alone. And so I want to look at the doubling times, but if they're getting some benefit from that first regimen, that's going to be the best, the longest term that they're going to get. So if they are doing well clinically, they don't have a lot of disease progression, and it's just PSA alone, I'll watch them closer, but I don't think I would change therapies. Dr. Morgans, what do you think?
I would agree. There's a really nice JCO paper that Howard Scher and team did probably 8 or more years ago. I think the patient was on abiraterone, and you can see the PSA rising, but there's no radiographic progression for several years, and so they kept that patient benefiting from abiraterone or whatever the agent was, but I think it was abiraterone for years. It was at least 3 or 4 years, and so I would agree. It's important, I think, for us to not act necessarily on PSA alone.
Now, what if you had a
But this is not a
PSMA
rising.
That would be a
CT?
mess.
Now, would that
Now
change
that
your
would be a
mind?
mess.
But this is
Yeah.
not a rising PSA. This is a PSA that doesn't nadir
Doesn't
properly.
nadir.
So in
So-
other words, yes, I mean, you're using PSA, but
Yeah.
I mean, Maha clearly showed that the survival was worse, and this more recent paper in the modern era showed the same thing.
But it doesn't say that switching treatment actually is going to fix that problem.
True.
So that's kind of, until we have, and there's actually a really interesting study that is in a radiation population that's saying, if you do your ADT radiation for high-risk disease, and you've got 2 years of planned ADT, if you don't nadir properly post-radiation, still on your ADT, they're actually adding APA, I believe, versus continuing your ADT to see if that intensification in suboptimal nadir actually makes a difference. I think those are the studies that we would need to do to answer the question.
And until then, I think I would watch that patient closely and just know that they are going to progress earlier than the other patients who've nadered to non-detectable.
Any other questions from the audience?
I love that you're designing clinical trials for us, Chad.
Yeah,
That's
yeah.
fantastic.
So, I had another question for you. Where do you think this is going? Do you think clinical trials are going to be incorporating the advanced imaging earlier on and, kind of do away with conventional imaging? But it seems like it's going to take a long time.
Yeah, I think that we have to integrate them into our clinical trials now, actually in conjunction with our standard imaging, so that we can understand how to interpret and almost maybe have a crosswalk between our old trials and our new data, new trials that's based on a combination maybe of conventional imaging and PSMA PET, so that we can say, well, high volume was this in conventional imaging, but it's this in PSMA PET. And if we're able to do that in our ongoing trials, we'll be able to at least sort of interpret things better.
For the, because these trials are global, so again, before we adjourn, for the country, for the clinicians in the various countries represented, by show of hands, how many people have easy access to some sort of PET scan? How many do not, anybody who does not have easy access? So, you know, a number, so again, for these global trials, it still might
Well,
not
you
be
know,
there
I
yet.
think that in Australia and Europe, they've been doing PSMA a lot longer than we have. And so they've been, you know, doing this, and we're kind of behind the eight ball when it comes to that, don't you think?
We're very behind the eight ball, but we're trying to catch up.
Yes.
Well, if there are no other questions, thank you very much for attending. I want to thank Dr. Morgans and Dr. Karsh, and I hope everyone enjoys the rest of their AUA. Thanks again for coming.
Thank you
Thank
very
you.
much. Thanks, Judd.